All right, good afternoon. Might be good morning or even good evening, depending on where you're joining us today. My name is Elizabeth Wren, and I'm your Clinical Preparation Program Manager. So welcome to our live demo on nasogastric tube insertion and peripheral IV insertion. So yes, you heard right. There's going to be 2 skills in this webinar. So once I am done with the nasogastric demonstration, Nancy's going to go ahead and turn off the camera, mute me, and for the next couple of minutes, bear with us as we switch over to the peripheral IV skill set. The other thing is, please forgive me if I am a little nasally, if I'm starting to clear my throat or cough on the side. I'm still recuperating from that cold that I got earlier this month, thanks to baby Hannah. And so please forgive me if you see me needing to go off camera to take a drink or a sip or two. So we'll go ahead and get started. All right, so today we're going to be going ahead and I'm going to do the live demo on nasogastric tube. So as usual, I always like to ask the pause and reflect. I want you to pause and reflect on, are you comfortable with this skill? Is this something that you routinely do in your hospital, or is this something that perhaps you don't see quite often in your area in nursing? Or perhaps this is something that a doctor or a surgeon or even a resident, what you call a junior doctor, might be doing on the unit that you work on, and perhaps you're not readily exposed to the skill itself. So a couple of things I want to discuss with you is just the supplies that you will need. And so you will definitely need, oh, somebody said pause. Hey guys, like I said, we've been having some glitches here with the GoToWebinar. I think that we changed the settings to our camera, so hopefully you're able to see me a little bigger. Not sure if that worked or not. But in the comment box, oh, somebody's commenting. Okay. All right. So it looks like some of you might have to log in, log out, and then come back in, because a few of you are saying that everything's good on your end. So just let us know if anything. Anybody else made a comment? Oh, here we go. Okay, so if you cannot see me and you think that I'm too small, go ahead and log back out, log back in, because it might be the internet connection on your end. I'm not sure. Okay, sorry about that. Like I said, GoToWebinar has been acting very glitchy here in the States. All right, so where was I? So we were talking about the supplies that you're going to need when you place a nasogastric tube. So you definitely need to have the NG tube. And so this is what we call a saline sump. This is a 12 French that I'm going to be using on our patient. And so typically, the average adult is going to be needing a 12 French, 14 French. Sometimes you might even see 16 Frenches in your clean utility cart. Now, if you are a pediatric nurse and you're going to be working with pediatric patients, obviously you would be seeing a smaller size in your supply cart. So typically children are going to have like 6 French, 8 Frenches, even 10 Frenches. But it all depends on your unit population. All right. And so you would also need to make sure that you have some water-soluble lubricant to make the insertion more comfortable for your patient. You'll need to have your nasal tube securement device ready. And then I also recommend having a pen light, because you definitely need to assess the nares and the oral cavity. And then I typically will have a safety pin, and that's going to help me secure the NG tube to my patient's gown so that they're able to get in and out of the bed. And then lastly, I did want to talk to you guys about oral hygiene. So with a patient who has a nasogastric tube, keep in mind that these folks are going to be not eating or drinking. They're going to be NPO. So it's important that we're offering oral hygiene on a regular basis because we definitely want to prevent any infection, any translocation of bacteria that's found in the mouth. Heaven forbid that that goes down into the GI tract and even worse, into the bloodstream. So make sure that you are following the hospital's policy in regards to oral hygiene and using the hospital-approved cleaning solution for oral hygiene. The other thing to keep in mind is that with no eating and drinking, being NPO, your oral mucosal membranes are going to dry up. So one of the things that I used to do, which I highly recommend, is getting these swab sticks that you can find in your clean utility cart, dip them in water, and the patient can moisten their lips and the interior of their mouth by just sucking on the top here on the sponge. This has a minty taste, so it gives them a little bit more comfort. And then also other hospitals will allow you to put some type of Vaseline lip balm to protect the lips and to make sure that the lips are kept moist. All right. The other thing that I want to show you guys is the 60 ml catheter tip syringe. Now, many months ago, as I was doing webinars, I would show you how to auscultate and verify placement. But as everything in nursing, things update, things change. And so we're not going to be auscultating for verification of the tube. But in this case, you would order an abdominal x-ray to be done at the patient's bedside to confirm placement of the tube. A lot of times, the reason why we do that is that a lot of times these tubes might migrate into the trachea, down into the lungs, and we need to have some type of diagnostic to confirm the placement. So I will demonstrate how to do auscultation or verification by auscultation, but note that that is something that we don't do anymore. The golden standard now is to get an abdominal x-ray so that you can confirm placement. All right? Okay, so we're gonna go ahead and get started. I will go ahead and get a pair of clean gloves. Now keep in mind that placing a nasogastric tube requires you to assess the patient. And so on the chat, I want you to go ahead and let me know what are some of the contraindications for inserting an NG tube into your patient. Meaning, you get an order to place an NG tube, but you know that you can't put it in because this is going to compromise patient safety. So take about 5 to 10 seconds to think about it and start typing into the chat. Yeah, if you don't mind. All right, so somebody said nasal polyps. Yep. All right, any facial trauma? Very good. All right, if you got an upper airway obstruction, definitely don't want to be placing an NG tube in there. All right, yes, basal skull fracture, absolutely, yeah. Okay, so somebody said esophageoesophageal or varices. Okay, good. Gastric bleeding, absolutely. All right, very good. So so great critical thinking. So yeah, if you do get an order for a nasogastric tube, but you know that your patient's history includes esophageal varices, or perhaps they have an active GI bleed, or perhaps they have a basal skull fracture, or even a cervical spine fracture, these are all contraindications for nasal gastric tube insertion. Other surgical procedures might include gastrectomies, or partial gastrectomy, or gastric bypasses, because all of that is going to be changing the anatomy of your stomach. Your patient no longer has a normal stomach. So really important that we understand our patient's medical history and surgical history so that we can best intervene. All right, so let's go ahead and get started with our demo. So of course, you want to go ahead and perform hand hygiene anytime that you come into the room. Introduce yourself, explain to your patient what you're going to be doing and why, and explain to them how long it's going to be taking them. Typically, a nasogastric tube should be no more than 10 minutes from start to finish. So I'm going to go ahead and put my clean gloves on. Of course, don't forget about the basics. So you would verify your patient's first name and date of birth, as well as any allergies. You want to make sure that the bed is at a good working height. Always protect your back. Apply good body mechanics. All right. And I'm going to make sure that my patient is in high Trendelenburg all the way up. Okay. And I just like to go ahead and drape my patient. I'm going to go ahead and place the MSN basin nearby just in case they start wanting to throw up. And before I actually get started with the insertion, I'm going to go ahead and set up my suction. So suction should be set up. This is your vacuum. And so here in the vacuum, it'll let you know, or it'll have like intermittent versus regular or continuous suction. And so just remember, guys, that anytime that you're receiving an order for a nasogastric tube insertion, get clarification from the physician or the surgeon and ask them, do you want it to be continuous or do you want it to be intermittent? And then keep in mind that nasogastric tubes should always be at low suction. So in this case, my vacuum is going to be anywhere between 0 to 80 millimeters mercury and no more. So that is what we considered low for this vacuum. The other thing that you want to keep in mind, guys, is the canister. So this particular canister is going to be able to hold up to 1,200 mLs of fluid or gastric content. So one of the tubings is going to be connected to the vacuum, and the other tubing is going to be connected to the patient, which essentially is connected to the NG tube, which obviously is inserted into the patient. So rule of thumb is always make sure that your canister, the top is always nicely sealed. Make sure that your suction tubing is always sealed as well, because that is one of the reasons why suction doesn't really work, is that we don't have good seals or tight connections. So always make sure that your canister is ready to go. So I'm just going to bring this tubing over, just make sure that my suction is working. Yep, there we go. All right. And so now I'm going to go ahead and take my pen light. I'm going to look up the nose, the nair, make sure that there's no obstruction. Go ahead and do a breathing test. Press on the nair, have the patient breathe out. And then it looks like this patient, we're going to go with the left nair. We're also going to inspect into the oral cavity to make sure that we don't have any bleeding, any ulcerations, anything that could do some damage to the oral mucosa. All right, so I'm going to go ahead and open up my packaging here. Yeah, just go ahead and lay this there. I'm going to take my lubricant. And just consider, guys, if your patient is anxious or if they're in pain, please make sure that you're addressing pain. Make sure that you're addressing potty needs before you get started. And then make sure that you address the rest of your 6 Ps at the end of your interaction. But a lot of times patients might need to have an extra dose of pain medication or even need to have anti-anxiety medication because the procedure itself is not fun for the patient. And so you definitely want to make sure that your patient is relaxed enough so that you can properly make the procedure happen smoothly. So what we're going to go ahead and do, I'm just going to remove the connection here. Or actually, I'm going to keep it. Or no, I'm going to do a demo later. All right, so what I'm going to do, I'm just going to go ahead and lubricate about 3 to 4 inches of my nasogastric tube. But before I do that, I'm going to go ahead and measure out from the tip of the nair down to the earlobe, all the way down to the xiphoid process. So it's about 55 centimeters. And I'm going to go ahead and go a little close to the camera, but as you can see, each marking is a centimeter marking tick. All right. And so basically you would add about 2 to 3 inches to that. So I'm going to say 60 is where we're going to end our insertion. So the average adult is going to be between 55 and 65 centimeters that we've inserted of nasogastric tube. Also, it's important that we know what number will be right there at the nair, because that's what we're going to be documenting at the end. So at this point, after I've done my measurement, I'm going to go ahead and lubricate. So I'm going to lubricate about 3 to 4 inches. And now I'm going to instruct Mr. Jones or Mr. McNeil, whoever this may be, to go ahead and look up. And on the count of 1, 2, 3, I'm going to insert. As I pass the oral pharynx, now I'm going to have the patient look down, chin down, and I'm going to have him or her take sips of water or do a swallowing motion. So I'm going to go down, be swift about it, guys. Don't be slow. And I am at 60 centimeters at this point in time. Now, because again, our new golden standard is to get an X-ray for verification, I'm going to go ahead and just secure my nasogastric tube. Almost looks like a Band-Aid. All right, and I'm going to go ahead and clamp the nasogastric tube as I wait for the X-ray to be done. So I'm going to take this topper right here, place it on the clear side of the tubing, and then I'm going to take the air vent and loop it around, and that's how we're going to clamp our nasogastric tube until we get verification confirmed. All right, so let's pretend that radiology just came, they did the abdominal X-ray, and it is confirmed that we're in the right place, right? So now I'm going to go ahead and connect the patient to suctioning. But I am going to show you, just as a demo, like I said, this is no longer practice, but for those of you that might go to facilities where the policy still is to verify via auscultation, I'll go ahead and show you that. But remember, golden standard now is to get that abdominal X-ray to confirm placement. So I'm just going to take my stethoscope. I'm going to take my catheter tip syringe, and I'm going to have about 30 mLs of air. I'm going to just clamp real quick, and I'm going to go ahead and place my catheter tip on the clear side, the clear lumen. And I'm going to go ahead and just lift my patient's gown. Place my stethoscope right where the stomach is located. And I'm just going to push some air, and I'm just going to verify that I can hear the air bubbling in the stomach, which I do. At this point in time, I'm going to go ahead and take my suction tubing that's already on, and now I'm going to connect it to the actual suctioning, and you should see gastric content coming out. All right. Another thing I want to make you aware is that this blue vent needs to stay unobstructed, needs to stay nice and free, because the free-flowing atmospheric pressure is what's helping decompress your stomach and being able to pull that fluid out of the stomach along with the suction. So at this point in time, I would take a little bit of tape. And what I'm going to do here, I'm just going to wrap it around like so. And I'm going to anchor my nasogastric tube and pin it to my patient's gown using the tape. There we go. And that way, our patient is able to move in and out of bed without the worry of it being accidentally pinned to the pillow or to the bedding of the bed, okay? So at this point in time, guys, my patients should be feeling some type of relief, especially if they have like a small bowel obstruction. They definitely are going to start feeling some relief. Now, when we are assessing our patient after an NG tube placement, we got to look to see what are the characteristics of the gastric content. So this is where COCA comes into place. That is your color and the odor, consistency, and the amount. Really important, guys, that we keep track of the output of our NG tubes or any type of tubes or drains for that matter, because this is telling us how the patient is healing from the inside out. So real important that we document that. Typical gastric content is going to have that very dark green, brownish color. And so just be mindful that if your patient has a high volume output, what are they at risk for? So in the chat, go ahead and let me know, what are they at risk for when they have a high volume output from their nasogastric tube? All right, yes, risk of aspiration. That is always going to be a risk for anyone that has a nasogastric tube, regardless of their age or condition that they're in the hospital. All right, anything else? Anything else? A high volume output, meaning let's say that when I place this patient on suction, we immediately see about 800 mLs of gastric content coming out. Yes, whoever said electrolyte imbalance in the chat, you're 100% right. Which electrolyte is the most concerning here? Okay, potassium. Yeah, so someone says sodium, but potassium is going to be that electrolyte that I'm going to be most careful with, followed by magnesium, because guess what? Where potassium goes, magnesium will follow. So if you have a high volume output, be careful for electrolyte imbalances. So what else? What else is your patient going to be at risk for? Yes, dehydration, that's another one. And what else? What if there's, like, we talk about electrolyte imbalance, dehydration. Yes, ding, 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 ding. Whoever said metabolic alkalosis, you are correct. Remember that gastric content is an acid. So if I'm pumping out all this acid and it's a high volume output, and I'm pumping out all of this acid, what's going to happen to the patient? They're not going to have any more acid. And so we're going to find ourselves in a situation where the patient now has metabolic alkalosis. So be very careful that when you have a patient that has a high volume output, that we're monitoring their intake and their output because they're at high risk for dehydration. And we're also careful with their electrolytes. We got to be doing frequent electrolyte checks because they could potentially have hypokalemia, which is low potassium. So really good answer, guys. So we'll go ahead and move on. So of course, Mr. McNeil will just put him all the way down. You want to go ahead and address your 6 Ps. So check on his pain, Make sure that he doesn't have any potty needs. Reposition if the patient so desires. Make sure that their personal items are kept close, including their call light, because now they definitely need to be calling you or the nurse tech for assistance to come in and out of bed. Make sure that your IV pumps are pumping adequately and correctly according to the EMAR. And then you also want to make sure that PO needs are being taken care of. Now, obviously, Mr. McNeil's not going to be eating or drinking, but guess what? You got to follow oral hygiene according to your hospital's policy. And then lastly, your parting. So at this point in time, thank your patient for the time that you just spent. Do hand hygiene on your way out and ensure that your communication board is up to date with anything that needs to be updated. All right, guys, so that's the live demo on NG tube insertion. So go ahead, give us about a minute or two as we switch over to the peripheral IV. And so Nancy's going to turn off the camera. She's going to mute me, and then we'll come back on.
Welcome to the webinar. You have entered as an attendee in listen-only mode.
All right, guys, can you see me? Can you hear me? Say yes. All right, awesome. Thank you guys for confirming. All right, so now we're gonna go ahead and shift gears and go ahead and we're gonna do the live demo on peripheral IV insertion. So again, just being aware of what supplies you'll need to have whenever you're placing an IV. But again, let's go ahead and pause and reflect. Is this a skill that you routinely do at your hospital? Are you an expert? Are you proficient? Or are you on the other side of that spectrum where, not too comfortable with IVs, or, this is a skill that the doctors do at the bedside at my hospital, so I really don't get much exposure. So good news is that here in the United States, nurses are responsible for putting in the peripheral IV. Now, the nice thing here at Avant, when you come to your clinical transitions program, is that you'll have the opportunity to practice with our models like what you see here, and you'll be able to master that skill in a safe learning environment with your CTP instructor. So just FYI that, you are not expected to be proficient in this skill, but we want you to be comfortable enough to pass our validation skills, and also be assertive and take the initiative when you start on your U.S. assignment. Connect with your preceptor, connect with your nurse educator, and let them know, hey, I'm not really comfortable with peripheral IV insertion. I need to practice. So, anytime that a patient on your unit, whether it's your patient or not, go ahead and initiate that conversation and see if you can be the one to do the IVs. I remember when I first started in nursing, and I was a graduate nurse, I did not like putting in IVs. I was scared of them, and I had only successfully placed 1 or 2 IVs when I was in orientation. So when I was a floor nurse all by myself, my little 21-year-old self, I always panicked anytime that I had to put in a peripheral IV. Well, I had a colleague named Sonia, and Sonia was our IV queen. Like, she would go into any patient's room and put in an IV, and bam, she was done. And so one day I went up to her and I said, Miss Sonia, I need you to help me. I am so afraid of IVs. And she said, you know what? Anytime anybody asks me for an IV, I'm going to take you in with me. And you're going to be the one to put in the IV. And sure enough, Miss Sonia needs to call me on my little phone. Elizabeth, room 1 needs an IV. Meet me up there. Or, hey, room 22 needs an IV. Come and meet me in room 22. And guess what? I became comfortable with peripheral IVs. And so many years later, as an educator, my nurses would come to me and say, hey, can you help us put an IV? So again, moral of that story is to take the initiative, seek out those experts that are, your IV kings and queens, and, learn from them, because I definitely learned a thing or two from Miss Sonia. All right. So here in the US, we have IV start kits. It has your tape, it has your cleaning solution, has your transparent dressing, including your tourniquet. And so let me double check to make sure. But, oh, yep, the tourniquet is in there. I always have to make sure. You definitely need to make sure that you have your IV catheter. And so this is a 20 gauge. It's pink. That's how I know it's a 20 gauge. And then I also have a 22 gauge just to show you. And so just keep in mind, guys, that anytime that you have an IV, I'm going to get up close here. You see where my finger's at? There's a button there. That is your safety device. When I press that button, the needle's going to retract. So that should be one of the first things that you do after you establish the IV in the vein, is to go ahead and retract that needle. I always like to have at least 2 IV flushes with me, nice and handy. There we go. And then you also want to make sure that you have your IV extension set as well. So as usual, make sure that you do hand hygiene. This is a clean procedure, so it is not sterile. And so just because it's not sterile doesn't mean that I'm going to take my extra precautions, because I definitely do not want to introduce anything into my patient's bloodstream that could potentially become an infection. So I'm going to open up my kit. Put my stuff aside here. I'm going to take my tourniquet. And what I'm going to go ahead and do, I'm going to go ahead and place my tourniquet about 2 to 3 inches above where I want to insert the IV. So I'm just going to place my tourniquet like so. And I'm going to use a slip tie knot method like so. We can show that knot. And so it's a fast release or a quick release knot. And I'm going to go ahead and I'm going to palpate. And I'm going to visualize my vein. But it's good to palpate because if you have a vein that has a lot of valves, you want to avoid that vein because you don't want to cause any type of infiltration in the vein. So vein looks good, looks healthy. And so now I'm just going to go ahead and release my tourniquet, but I'm going to keep it nearby. At this point in time, I'm going to go ahead and use my cleaning solution wand. I'm going to activate it, allow that solution to saturate the cleaning sponge, and I'm going to start cleaning. And the way that I'm cleaning, guys, is that I'm using the same application or the same method as if I were doing a central line dressing change. So up and down, side to side, very vigorously, because that is what's killing the biofilm in your on your skin. And so I would challenge you guys to look on the internet and just type in the word biofilm and see what kind of gnarly pictures that you see that are microscopic on your patient's skin, because I can tell you it ain't pretty. All right, so we're going to clean this for about 30 seconds, about a 2 to 3 inch diameter of where you're going to be inserting the catheter. Now, your facility here in the United States might have you scrub for 60 seconds, 90 seconds. I worked transplant, so all of our patients were immunocompromised. So we had to scrub at least 60 seconds and allow 90 seconds of dry time. All right, so while that is drying, remember, no blowing, no fanning, no patting dry, because then we've contaminated the area. So just let it air dry. So while that's letting air dry, this is a good opportunity to go ahead and prime your IV extension set. So I'm going to take one of my saline flushes. I'm going to connect it like so to my IV extension set. I'm going to just prime. And I'm just going to be very careful. I'm just going to loosen the top of here. I'm not going to completely uncap it because I want to protect the hub here, because that's what's going to be connected to my IV catheter. So don't want to make it too tight. Just going to lay this down like so. And at this point, I'm going to go ahead and put my tourniquet back on. Okay, and that vein just popped up. But I'm going to avoid touching that area that I cleaned because I don't want to contaminate it. So I'm just going to go ahead and situate my patient's arm. Sometimes you just got to maneuver your arm. I'm going to use a 20 gauge needle. And I'm going to go ahead and make sure that the bevel of the needle is up. I'm going to anchor it. I'm going to go ahead and taunt my skin back, make it tight, straighten out that vein. And about a 10 to 15 degree angle, I'm going to go ahead and tell Mr. Jones, all right, on the count of 1, 2, 3, Mr. Jones, I'm going to poke, 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 poke. All right, so I am in the vein. I see blood return. I'm going to go ahead and I'm going to slide that catheter into the vein. I'm going to untie my tourniquet, and I'm going to take my 2x2 gauze. I'm going to just place it like so underneath the catheter because I know it's going to get bloody. I'm going to take, because my catheter is all the way into the patient's vein, I'm going to go ahead and hold the vein tight so I don't get that bleeding. I'm going to remove, and now I'm going to activate that safety device. Woo. And now I'm going to go ahead and take my extension tubing, place it like so. I'm going to screw it on. And I'm going to remove this. I'm going to clean out my patient here. And I don't know, Nancy, if you can see, but I got some good blood return in my vein. All right. So I'm going to go ahead and just flush. Very good. All right. I'm going to have the patient just hold tight. I am going to now secure the IV with my transparent dressing. I'm going to remove the labeling here. And I'm going to take my pen. And I'm going to initial it. I'm going to date it. And I'm going to put today's time. Some labels will actually have you put in the gauge number. You can, if that's required of you. All right. So I like to do a second flush just for good measure, just to make sure that we got good patency. And you always want to make sure that your patient is also having no pain, that there's no signs of infiltration or phlebitis. So I'm going to take a little bit of tape, you all. And I'm going to go ahead and just loop my extension tubing like so that it's not flip-flopping around. Just placing that on my patient. And then I'm going to go ahead and clamp my clamp so that I don't get any bleeding into the catheter itself. Just going to remove these items real quick. Place them in my sharps box here. No need for my tourniquet anymore. And now what you see is a beautiful peripheral IV. So the next thing that I'm going to do is I'm going to go ahead and document my IV and how the patient has tolerated the insertion. So I'm going to go ahead, perform my 6 Ps, make sure that on my way out that my communication board is up to date. And guess what? I got to do some hand hygiene on my way out. All right, guys, well, that concludes our live demo on peripheral IV as well as nasal gastric tubes. So, Nancy, what questions do we have in the chat? Yes, so somebody had asked in the chat, is there a recording that we can do later? Yes, that is in your CPP webinar series in Learn Upon. Hopefully everyone's watching those. All right, so somebody asks if we aspirate gastric content and check for the pH level. Here in the States, we don't do that. So again, current practice is that we're getting that abdominal x-ray to confirm placement. So someone asks, does it matter what nostrils based on your position? Does not matter. I mean, if you're left-handed, stay on the left-hand side. If you're right-handed, you can do the right. But as long as both nares are both patent and that they are free of obstruction, then you can use either one. All right, can the head of the bed be lowered when having or passing a nasal gastric tube? That's not best practice. Patients are at risk for aspiration. So always make sure that your head of the bed is elevated to at least 30 to 45 degrees. Say that one more time. So someone asks, how did I perform the breathing test? I'm not sure if you're meaning the auscultation verification, but I just did that in my my demonstration. So don't know what breathing test refers to. So if somebody has an affected limb, like let's say you have a stroke, or let's say you have somebody that may have had lymphedema or lymph nodes removed, like what you see in mastectomies, typically those are extremities that we would avoid using. So you would use the opposite extremity. And of course, if you're having some trouble with accessing, you may have to have a physician's order to go ahead and access the patient's opposite arm that has the mastectomy or lymph node removals, or the lymphedema or the stroke. Oh, somebody asked, how do we get learn upon accounts? So when you are enrolled in CPP, you should have gotten a learn upon account set up by your CPP specialist. So if you have any questions regarding your modules or webinars or how to access them, please make sure that you're emailing your CPP specialist. So somebody said, like, when do we stop continuous suction? Well, it needs to be a doctor's order. If the physician says to have a continuous low suction, then that's the order. But if you feel that the patient might not be tolerating that very well, call the physician or the surgeon, let them know, and get an order for it to be switched over to intermittent. Okay, so someone said, like, before, as I'm labeling, I did keep my gloves on. But yeah, if you want to remove your gloves, you can, but make sure that you're doing hand hygiene right afterwards. Always make sure that you're protecting yourself from transmitting any bacteria or anything to your patient or its surroundings. So I'm thinking that the next question is regarding the NG tube. So if we throw away the contents that we aspirate, absolutely not. If you're aspirating to check residual, that residual needs to go back into the stomach because this can cause electrolyte imbalance or dehydration. Now, obviously, content that's been collected in your canister, that has to go in your biohazard bin because obviously that's stuff that can't come back into the patient. So I hope I clarify that. All right, so how frequently do we change the NG tube? NG tubes are designed to last pretty long as we're maintaining patency and that we're checking for patency during our assessments. So I would say I've seen a patient go as long as 10 days with a nasal gastric tube because it actually was maintained pretty well. Oh, somebody asked, do we have infrared vein search, like the vein finder? So it depends on your hospital unit. It depends on your budget on the unit because those are very, very expensive. I had one on my transplant unit just because our dialysis patients are very, very hard sticks. And so it was worth the investment in having a vein finder for those specific patients. So it just depends on your unit. All right, so how long can the peripheral IV stay in? Depends on your hospital's policy. I believe that current best practice is that we are rotating the peripheral IV at least every 7 days. Yeah, so if your patient has tattoos on their arm, I mean, we have to access the patient because we're giving medications. This could be a life-saving measure. So yeah, unfortunately, if your patient does have tattoos, you may have to insert into the tattoo. All right, so some of the acts, like, how do we address the patient's radiation exposure with every NG tube insertion? Because I get, best practice has changed to where we are using radiography to confirm placement. The thing is, guys, is that remember, an NG tube is pretty much a one and done thing. You're not doing these things frequently unless the patient pulls out the NG tube or it falls out on its own. So I don't want you thinking that you're putting in NG tubes every day. That's not going to happen. So just being mindful that this skill or this procedure is probably just a one and done deal, and for your patient. Yeah. Yeah. All right. So what is to be documented when it comes to the peripheral IV? It's basically, how many attempts did you that you did in order to put in the IV? The patient's tolerance. Is there any evidence of phlebitis, infiltration, and what was the solution that you used to verify? So in this case, it would be saline flush that we use in order to verify placement of the IV. All right, some of the acts. Do we need a consent for NG tube? Typically, the universal consent that patients sign upon admission is going to cover interventions such as NG tube placement. All right, well, guys, I believe that was the last question. Thank you so much. Thank you for all of the critical thinking that you guys displayed today. I hope everyone has a fantastic weekend. Please stay safe and healthy. And if you have any questions, please make sure that you reach out to the CPP team. Until then, see you next week. Bye.